Welcome everybody to Sepsis Education Night from the UW Health. My name is Mike Lohmeier. I am one of the emergency medicine physicians here at the UW. I'm also one of the medical directors for several of the EMS services that we provide medical direction for here in Dane County. I was chatting just a little bit with Corey before we opened up the presentation here tonight. I am really excited to have the number of people that we have online right now. I think that we're pushing close to 300 participants or more, which is an incredible audience, and it's an incredible honor for me to be able to talk with this many people. Corey and I were going back and forth quite a bit about the pros and the cons of the pandemic, and I think while the cons absolutely outweigh the pros, we've had a couple bright spots, and I think that upping our distance education game is one of them. And so thank you for giving me the opportunity to come and speak tonight about sepsis. I'm going to spend the next hour just going through a few high-level topics. I'm going to try and breeze through this so it's not too dense. And feel free to throw in any questions into the chat. Corey's going to be monitoring from the back of the room for me if anything comes up. I realized as I was just getting started up here that I did forget to put in my disclaimer slide. I don't have any significant financial disclosures to make. Nobody is paying me under the table to be here tonight. This is something that I get to do because I like teaching and I like being a part of the education center. So with that, I think we should go ahead and jump into our talk. This is my money slide for tonight, basically. If you don't get anything else out of the rest of this next hour, the thing that I want you to take away from this is that sepsis and shock in particular are bad actors for our patients. Even with one low blood pressure at any one time, shock has a mortality rate between 20 and 80%. And when you break those numbers down, obviously cardiogenic shock is significantly worse than septic shock, but sepsis is no bad actor either. If you have somebody who is in sepsis, they've got shock, they've got low blood pressures, and if you aren't really aggressive and on top of it, you're going to be behind the 8 ball before you realize it. So hopefully that's the take home you get from this, is that we need to be aggressive and we need to be on point when we're dealing with sepsis and septic shock. I'm going to start you off with a quick case here to lead in. So this is a real case that came into the university a couple months ago. This is a 75-year-old male. EMS was called because he was reportedly unresponsive at home. The EMS radio report came in at about 2:30 p.m. The initial call was a stroke code. The call was a 75-year-old male who was last known well at 11 a.m. He was not able to speak as far as the radio report goes. EMS said that he did not have any chest pain. They were able to establish a peripheral IV and that they had started normal saline infusions with an epi infusion at 20 mics per minute. The radio report, vital signs, first blood pressure 68/40, heart rate of 62, respiratory rate of 32, O2 sat of 94% on room air, and his finger stick blood sugar was 200. The crew was on point. They got an EKG for this gentleman early. I suspect a lot of it was because he wasn't able to give much of a history, so they're casting a wide net, which is totally appropriate. Here's his 12 lead. Nothing really jumping out so far. He's got a right bundle, but otherwise we're good. So he arrives in the emergency department, and this is where the emergency department notes pick up. So on arrival, he is answering some questions. He's speaking in one-word sentences. They note that he's got some left-sided hemiparesis, left-sided weakness. He's not moving his left arm or his left leg very well. They note that his speech is slurred. The notes state on first arrival, he's alert to self and place. He's endorsing pain, but it's really not specific as to what hurts at that time. Reading on a little bit farther, it sounds like he had some back pain. So the EMS report was at 1427, 1431, first set of vital signs, blood pressure of 86 over 43, heart rate of 62, respiratory rate of 26. SpO2 at that time is 92% on room air, and they measure a temperature on this gentleman of 85.6 degrees Fahrenheit or 29 degrees centigrade. All right, so question 1. Fire your answers into the chat box here. What's your general assessment of this patient? A, code stroke. He's got left-sided weakness. He's got some slurred speech. Last known well of 11 o'clock. Are we going to buzz him off to the CT scanner? Is this guy a STEMI activation with that funny-looking EKG that we showed earlier? Could this be C, a seizure? D, is this a diabetic emergency? He's got blood sugars of 200s. Could this be a DKA type picture? Or option E, sepsis? E and A seem to be our leaders in the clubhouse. So it's kind of funny, right? I'm up here talking about sepsis night, and sepsis is going to be one of the options on here, okay? Yes, so E and A are our two most common answers. I'm going to continue this case, and then we'll double back to what the answer was here. So continuing on with case number 1, this is from the resident notes that saw him. So he's altered and unable to provide a history. They were able to get his wife on the phone, and they got EMS to assist. Turns out he had had a Foley catheter placed for about the last 2 months for some urinary retention of uncertain etiology at that time. His wife said that he had been complaining of some increasing fatigue and generalized weakness for the last few days, but nothing really specific. That morning, he woke up and was telling her that he didn't feel great, maybe felt a little bit weaker than the day before. She went about her business, was outside doing some yard work, and then when she came back inside at 11 a.m., she found him to be incoherent and activated EMS at that time. So his physical exam, we've got a trend now of some vital signs. Blood pressure 84 over 48, remaining pretty stably hypotensive with a systolic in the 80s. His heart rate is stable in the 70s. And his pulse ox is now 100%. And I'm going to get to a little bit more of that in a couple slides here. The significant parts of the physical exam, I think, are bolded on here. So his lung exam, they felt that his lungs were clear to auscultation to the anterior fields. He wasn't wheezy. On his GU exam, there is a Foley catheter in place with a bunch of purulent fluid. So he's got a Foley that's full of pus. And on his neuro exam, he's oriented to self and hospital. Otherwise, he can't give any history. And they felt that he was moving all of his extremities equally at that time without any obvious deficit. All right. So we have a guy who is progressively weaker over a few days. He's got a Foley catheter that's got some pus in it. He's had some intermittently documented left-sided weakness. And now he's trending his vitals. He continues to be hypotensive with a normal heart rate. What are our concerns? What's our differential here? What do we want to do with this guy? Good. So I'm hearing people are leaning more towards a sepsis picture, right? Have we ruled out a stroke in this guy definitively? Could he be urosepsis? Could he be just a chronically colonized Foley catheter now, since it's been in for 2 months and he is having a stroke on top of it? So I'll tell you a little bit more of the story here. So the stroke team was activated on arrival because they did feel he had some left-sided weakness. The stroke team came and evaluated him with the emergency medicine team. And together they kind of took a look at this guy. They said persistently hypotensive, altered mental status. He's hypothermic. Their leading horse in this race was more infectious than it was ischemic stroke or hemorrhagic stroke. And they felt so uncomfortable about it that they decided to intubate him. They didn't decide. They made the appropriate decision to intubate him for airway protection before sending him over to the CT scanner. So while he's over in CT scanner, some of his labs start to come back. Notably highlighted in yellow here, he's got an elevated white count at 16. His first venous blood gas is pretty dramatically acidotic. His potassium slightly high at 8.1. There's a little bit of sarcasm there. 8.1 is like through the roof. And his creatinine, which normally runs in the 1.4 to 1.7 range, is now 11.7 here today. He got his head scan after his airway was protected. There were no signs of ischemia or hemorrhage on his CT. So to just round this one out, what's making him sick? I think we've hit this one at least twice now. This guy is sepsis, most likely a urinary source. It's probably been brewing over the last 2 weeks, and then he just tipped into it. Is this patient in shock? He's super sick, right? Yes, absolutely, right? But he doesn't have a fever. Does that matter? No, he's hypothermic. He's so sick, he's on the other end of the spectrum, right? This dude is getting ready to check out. The points I wanted to drive home here are really a couple nuanced ones. So just remember that to be in shock, to be in septic shock, you don't have to be hypotensive by definition. It's part of it, having a low blood pressure, but really the measurement of shock is having signs of end organ dysfunction from inadequate perfusion. So you could have a normal-ish blood pressure, you could have a systolic in the 110s to 120s, but if you've got altered mental status, if you've got acute renal failure, if your lactic acid is going up, if you're acidotic on your blood gas, or if you've got evidence of acidosis on your end tidal CO2, right? Those are all signs that you're not perfusing well, even with a decent blood pressure. Okay, so just remember, shock does not mean it's hypotension. Hypotension can actually be a late sign in a lot of these people. Okay, so why are we here tonight? So we are here to learn a little bit about sepsis. And that first case, I think, is a pretty illustrative one of how quickly these things can go downhill. What are the things that actually make a difference in improving patient outcomes in septic shock? And I'm going to go through each one of these one at a time for you here over the next couple minutes, and hopefully I can convince you that these are listed in decreasing order of importance. Okay. So really, the most important ones are going to be early detection, early antibiotics, and early IV fluids. And when we get to the end, I'm going to kind of show you why this is important for this audience and how your assessments really are the things that make a huge difference for patients. So when I was putting this together, a couple other things popped into my mind. You know, we've got the biz buzzwords that are always floating around, and we talk about SIRS criteria. Is this patient SIRS-y? Are they SIRS-y, or are they sepsis? Are they sepsis, or are they severe sepsis? Are they in septic shock? And these terms are really kind of misleading, and I don't know that they really get you to the answer that you're going to, okay? So just a few slides to really kind of drive that point home. Just as a reminder, SIRS criteria, the systemic inflammatory response syndrome that we spend so much time thinking about and talking about, especially in sepsis, there's 4 criteria, and if you have 2 or more of any of them, then you have positive SIRS criteria. So the 4 criteria are fever of greater than 38 degrees centigrade or hypothermia, a temperature less than 36, tachycardia with a heart rate greater than 90, tachypnea with a respiratory rate greater than 20, and then a leukocytosis, an elevated white blood cell count greater than 12, or a low white count of less than 4. So just thinking back to our guy, he was hypothermic because his first temperature was less than 36 centigrade. He was tachypnic with a respiratory rate greater than 20. And we didn't know it at the time, but he did have a leukocytosis. So he's got 3 out of the 4 right off the bat there. why am I making a point out of this? Well, the thing that's important to remember is that SIRS criteria really is not a perfect net to catch everybody. And, looking at this paper from the New England Journal, they estimate that 1 out of 8 patients who have severe sepsis may not meet the SIRS criteria by the definition that we've got out there. But if they do meet the SIRS criteria, obviously their morbidity and their mortality is significantly higher. So if you're sepsis and you're SIRSy, you are bad news tennis shoes, right? It's tough to pick these things up. It's hard to pick up who's sepsis, especially as we get into some of the elderly patients, some of the cases of dementia. Some pediatric cases are really hard too, because it's difficult to communicate and get a good history. So a lot of those criteria are difficult to meet. Really great graphic that I think drives this home, right? So when we look at the overlapping Venn diagrams here, you've got your SIRS criteria on the right, you've got your infection on the left, and then sepsis is where the two of those bad actors come together in the middle, okay? Now, just as a reminder, infection can be bacteria, fungi, parasites, viruses, right? I think we've all seen some patients who were septic from their COVID infections lately, right? They are tachypnic, they're febrile, they're hypotensive, they're tachycardic, they've got low white counts. That's kind of the classic one for the bad COVID infections. They're sepsis too, and they bleed into it. But remember, SIRS criteria, that inflammatory response, it catches a few other conditions that aren't infectious as well. So things like bad burns, trauma, pancreatitis, other inflammatory conditions can look very SIRSy to you as well. So why do we care? Okay, so how this really got started prior to 2001. So we're not talking ancient history, right? This is not like the 90s. Right. We're talking 2000s. We're talking modern era. We really weren't that great at managing patients in sepsis and septic shock, particularly in the emergency department. Patients would come in. We developed that kind of sick, not sick criteria. You can sort of eyeball them and you can tell who's in trouble. And we kind of got at them, but the fluid resuscitation was variable. What antibiotics we chose was up to the provider. How much fluid was variable. When did we put them on pressors? Where did they go? And what we found was that universally we were pretty terrible at managing sepsis, and patients were having significantly bad outcomes related to our inability to be more proactive. So the gentleman in the picture on the right, that's Dr. Manny Rivers, and he is somewhat of the Zen guru of sepsis management. So in 2001, he did a study at Henry Ford in Detroit. And what he did was he kind of took a step back and he said, why can't we protocolize the management of these people? They come in, we know that they're sick. We've got criteria that say that they're sick. How do we hit them early, hit them hard? How do we, we're here to save lives. We're not here to just watch people kind of flounder and die. So what he did was he developed 5 separate parameters and criteria that he wanted to manage. His goal was to get all of them managed within 6 hours of the patient arriving in the emergency department. And what he proved with his interventions was a 16% reduction in mortality. So not just bad outcomes, long hospital stays, long ICU. 16% of the people that were going to die, he saved them by his interventions. And this was a landmark study. This was a big deal, especially when I was in residency. So what are the criteria that he looked at? So Dr. Ramirez said someone comes in, they look like they've got sepsis, they're in septic shock. We want to get a CVP on all of these patients. So a central venous pressure. What does that mean? That means they were getting central lines. Either we were dropping an IJ, an internal jugular line, or we were placing a subclavian line on them. And then we were measuring how well perfused they were based on what their central venous pressure was. If it was over 8, then we would move on to measure their MAP, or their mean arterial pressure. If it was less than 8, then we were hitting them hard with the IV fluids up front. Get them fluids, get them resuscitated, check their MAP. If their MAP is still less than 65, then we're starting them on pressors. And then we move on to their SCVO2, so how much oxygen content is in their venous side. And if they're low on their labs, then we're transfusing them red blood cells, and we're starting more pressors to get them better perfusion. Okay, super, super aggressive measurements. And I started my training in the emergency department in 2006, so 5 years after his study was published. And this was kind of the gold standard that we held ourselves to. If someone came in, if they were septic, if they were shocky looking, we were dropping central lines on them. We were starting them on pressors. We were ordering up blood products for them, and really super aggressive because of the findings that Dr. Ramirez had. Now, as with every good scientific breakthrough or landmark project, there's always a few people who are a little bit skeptical. And so what these studies did, the ARISE, the PROMISE, and the PROCESS studies, was they said, yeah, okay, that looks great. We're getting good outcomes for these patients. We're saving people who otherwise wouldn't have been saved. However, a central line is a big deal. You have a lot of complications. You can develop infections from your central line. You can drop a lung. You can develop a clot or a PE from that. Blood transfusions, huge deal, right? All the risk of infection, all the complications that come with that. And then we're talking about starting pressors on people and increasing their squeeze. So the ARISE studies, okay, so I lied to you. There's two things I want you to take home from tonight, right? 1.1, sepsis, septic shock, all shock is bad for our patients, right? Even one low blood pressure along the way, if they're sick, is a pretty significant indicator of their mortality. 2, if you want to write a great study that gets published and gets people to read it, you got to come up with a cool name for it, right? So ARISE, PROMISE, and PROCESS. So the ARISE study was the Australian Resuscitation in Sepsis Evaluation, ARISE. This was a multi-center randomized controlled trial. And what they did was they compared the Manny Rivers early goal-directed therapy, EGDT is what they called it, versus the standard of care. And so what they wanted to do was compare early goal-directed therapy to the standard resuscitation practice. And their hypothesis was that early goal-directed therapy would reduce all-cause mortality in patients who came in with sepsis. The PROMISE study protocolized management in sepsis. They wanted to estimate the effects of early goal-directed therapy compared to usual resuscitation on mortality at 90 days. They were also looking at cost effectiveness incrementally over a year. And then the third study was the PROCESS study. And this one was, where's my pointer? There we go. The PROCESS study was protocolized care for early septic shock. This was a big one. This was a multi-center randomized open label trial that happened in the United States, 31 academic centers, enrolling patients from 2008 to 2013. And what their analysis was an intention to treat. And again, they were comparing early goal-directed therapy, the Manny Rivers protocol, versus standard therapy. Now, what all three of these studies ended up turning out was that, one, they showed a reduction in the number of patients who got a central venous catheter. So half or a little less than half of the patients who were going to get that big garden hose either in their neck, in their groin, or in their subclavian did not get one. The blood transfusion rates in the standard treatment arms were half of what they were in the Rivers protocol. The pressor rate was cut by almost 10%. And then they reduced the use of the SCVO2 or the central pressures to guide their therapy. Now, the significant thing about this was that they did not find any statistical difference in outcomes. Where you say, how does that make sense? I spent 2 to 3 minutes telling you that we sucked at doing sepsis management and saving patients until Manny Rivers came around. And then we compared the standard of care to the Manny Rivers and found out there actually wasn't a difference in the outcomes. Well, the answer, the quick and dirty answer, is that we started paying attention better and we started having more structured approaches to sepsis and septic shock. Okay. And a lot of the hospitals nationally came up with what's called the Surviving Sepsis campaign. And so they were very aggressive about early identification of patients who were in septic shock with protocolized management strategies. And then they would still escalate to those more advanced measures that Dr. Rivers had advocated for. But it was more of an opt-in strategy than an opt-out, meaning if you came in and I thought you were septic, Manny Rivers would say, put a central line in that person right away. The Surviving Sepsis campaigns that got started subsequently would say, fluid resuscitate first, and then if you still need that central line, you go for it then, right? Didn't exclude it, but cut down the number of cases that we had with it. The protocols in Surviving Sepsis, so one, they need a lactate level when they hit the door. We want blood cultures drawn as early as possible, definitely before they start their antibiotics, so we can make sure we're tailoring our antibiotics to the right bug. Broad spectrum, big gun stuff up front, and then we want to do a 30 ml per kilo bolus of crystalloids if they're hypotensive or if their lactate's greater than 4. Okay? Makes sense, right? This person's sick. Everything about their vital signs and my impression of them says they're sick, and we need to attack it in an organized fashion. And then at 6 hours, if they're still hypotensive after they get their fluids, then we're going to start pressors. If they're persistently hypotensive, even after fluids, then we're going to do tissue perfusion measurements, so that SCVO2 and then repeat lactates. And then we want to make sure that they clear their lactates as we hit them with the big guns. Okay. And unfortunately, I moved this chart a little bit off the screen, so it's hard to read. But basically, what it means is don't just have that septic sick patient come in. You kind of throw a little bit of fluids at them, and then you set them aside and wait for them to get admitted to the hospital and someone else to see them next. It was bird dog them, identify them early, treat them aggressively, and then follow up, right? If they haven't gone upstairs yet, I need to repeat my assessment on this patient, and I need to double down on my interventions if they're not getting better. Okay. One of the things that help decrease the number of central lines is ultrasound, right? So we were doing cardiac ultrasound and taking a look at how dilated their inferior vena cava was after getting fluids. We would do a passive leg raise and see if if they had enough fluids on board, or if they needed more fluid resuscitation. And we used that to drive the fluids more than we did the central venous catheters. So for the Surviving Sepsis campaign in the ED, the things that we wanted to get a lactate, send blood cultures, broad spectrum IV antibiotics, IV fluid boluses, start them on pressors, and then repeat a lactate. How many of those interventions can be completed in the ambulance even before they arrive? And how many of them can be completed in the golden hour? Yeah, good. Yeah, right. So I would say the answer to this one is between the 2 and the 3, right? So if you're in the back of the ambulance with a septic patient, most services in the state of Wisconsin do not have broad spectrum antibiotics, and they do not have the ability to measure lactates. They could draw a blood culture potentially if you've got the vials for it. But really the big things that you would be able to do in the back of an ambulance is you're going to be able to start their fluid resuscitation, and you can advance them to pressors if they need it, so you can increase their tissue perfusion, right? Lactates, repeat lactates, and antibiotics are really going to be the realm of the emergency department. Now, I would argue in some of these really sick people, I don't know that I can even reliably get a lactate down to the lab and back before I know, before my golden hour has really gone up, right? So this is being really aggressive in identifying it early. So one of the things that we love doing, especially in the hospital, is coming up with cutesy little scores for everything. So you may have heard of the SOFA score, the Sequential Organ Failure Assessment Score. And what we do with the SOFA score is you take a look at someone's respiratory status, their cardiovascular status, what their liver function looks like, if they have any problems with coagulation of the clotting cascade, and then what their neuro GCS is. I'm going to argue here that a lot of these things take a significant amount of time to come back, right? And in a couple slides, you'll see why it's important, but obviously the earlier we identify infections and the earlier we start treating them, the better off we're going to be. To me, someone's FiO2, their PaO2, their LFTs, their coags, they're all going to be indicators of where the ship is, but it's not really, it's a good marker of where the train's at, but it doesn't tell me how fast we're going down the tracks, right? So the score that maybe more of you have heard of, especially with this audience, is going to be something called the Q SOFA score, right? And I love this because it's a retro, old-looking couch that, I don't know, it looks comfortable. I want to take a nap on this, except I think it's probably the most infected and gross couch that could possibly be in the world. The Q SOFA is the Quick SOFA score, the Quick Sequential Organ Failure Assessment score. And really, it's just based on 3 criteria. So are they hypotensive with a systolic less than 100? Do they have altered mental status? Do they have a respiratory rate greater than 22? If they've got a score of 2 or more on their Q SOFA score and we think that they're infected, these people are going to have a bad outcome. And we need to start early with the aggressive resuscitation, right? So getting that lactic acid, getting those blood cultures. So the surviving sepsis goals have continued to advance from the 2013, and now they were talking about 3-hour goals. We've now got the 1-hour bundle, right? So in that first hour, I want everyone to have a lactic acid measured. I want blood cultures drawn, and I want the big gun antibiotics coming right in behind them. And then they're going to get IV fluid boluses as soon as they hit the door, as soon as we've got good access of 30 mLs per kilo if they're hypotensive or if they've got an elevated lactate level. The 6-hour goals are still there, right? So reassess that person, at 6 hours, repeat their lactate if it was up at the beginning, because that's a good marker of poor tissue perfusion, reassess their volume status, add pressors if they're still hypotensive, and our goal for these patients is to keep their MAP greater than 65. But early detection, right? We want to nail these patients, and the faster we can do it, the better off they're going to be, okay? Next step is this is part of that 1-hour bundle. We want to get them their broad spectrum antibiotics in as fast as possible. Now, this is a very, I think, subtle but powerful slide from the Journal of Critical Care in 2006. And what this does is this looks at the increased risk of death in septic patients for every hour that their antibiotics are delayed, okay? Why is this curve significant? Why is this important? You can see, obviously, for every hour that we know that they're septic and we don't do something about this, their risk of death continues to climb, right? That's not a big surprise to anybody. I think the thing that's really surprising on this one is that as a comparison, for every hour that we sit on a person with an aortic dissection that we don't do anything, their increased risk of death is only 1%. So if you have a septic patient, for every hour that you don't do something to help that person, they have a 1.5% increase in their chance of death. If you've got an aortic dissection, which is kind of our big deal bad injury, they've only got a 1% chance of death for every hour. So big deal, right? Lots of people can be saved by early interventions. And then another graphical presentation of the same data. But really what I want you to look at is kind of this inflection point, the LD50 at the 3-hour mark, right? So you can see after that point, the survival curve just drops off pretty precipitously if we aren't getting them their antibiotics and getting their hypotension treated early, right? So again, get on them, hit them hard, hit them early, and that's how you're going to change those death curves. The answer to that one is probably a little bit nuanced. So it's going to depend if they're fluid responsive or not. And you can usually eyeball that pretty quickly as they're getting their serial blood pressures, right? So if someone hits the door in the emergency department They are hypotensive. It's our guy from case one, right? He's got pus coming out of his Foley catheter. He's hypothermic. There's no doubt that this dude's sick. He's got a low blood pressure. I'm going to start his IV fluids at 30 per kilo. And if he's not making trends in the right direction in the first 10 or 15 minutes, I'm starting to calculate what his norepinephrine infusion rate is going to be, because I'm going to continue to push that forward. If I allow him, the longer I allow him to be in shock and not perfusing his tissues, the worse he's going to be. The longer he'll be in the ICU, the worse his outcome, the higher his chance of death is going to be. And a little bit of the thunder's been taken, but to give away my end point here, my 30 per kilo bolus does not start when the nurse or I in the emergency department hook this cat up to his IV fluids. This starts when EMS gets his fluid resuscitation started, right? So if you pick somebody up, and again, we're getting to the end of the talk at the beginning, but I think it's worth reiterating here too. Your identification of someone who's septic and who's in shock is going to have even more impact than mine will. And what I mean by that is you're going to start their fluid resuscitation early. You're going to call ahead and say, I've got a code sepsis patient, so that I'm already on the ball to know I got someone who's getting resuscitated, who's going to need pressors, who's going to need antibiotics, who's going to need IMC admission. That is the epitome of teamwork. That is how this system really helps save people, right? So my feeling is, if you've already started your 30 per kilo bolus as you're bouncing down the road on the way into the U, you hit the door and case one is still hypotensive, I am throwing pressors at him immediately and going from there. Great question. So if the person is septic shock and if they're fluid responsive, so you're giving them their 30 ml per kilo bolus, you're getting it started and their blood pressures are trending up, I would keep them in my back pocket, but I would have a low threshold to put them back on if they look at me sideways twice, right? Because at the end of it, and we're going to get there, right? The bottom two are source control and ICU care. Until we do something to eliminate the source, right? The patient from case one needs to have his bladder irrigated. He needs to have that Foley changed out. He needs to have his infectious source cleared so his antibiotics can take effect. You're not out of the woods until you get that source control, right? And so fluid resuscitating them and starting them on their pressors early are hugely helpful to their outcome, but it doesn't save them necessarily. I like fluids. We're going to get to that in just a minute. Preferentially, warm fluids are good because these patients are at risk of going into DIC, so disseminated intravascular coagulopathy, just like the trauma patient, right? So if you get a trauma patient too cold, they go into florid DIC, they start bleeding everywhere, you lose that game 9 times out of 10. Same with the trauma patient. They get cold fluids, you lose that resuscitation attempt. So warm is better than cold, but I'll take whatever you got, to be honest. Leads us right into our next point. So early IV fluids. This is a great study that was actually conducted by two of the authors, are Haney Katab and Michelle Hughes, who are now faculty over at the UW. So just a little bit more of a toot of the horn for the U, having some really great docs. Early IV fluids improves mortality. So that 30 ml per kilo in the first 3 hours has a 50% reduction in mortality, and it reduces their ICU stay by 2 days at least, right? So these are real numbers. 50% cut in mortality. Half the people who were gonna die won't if you aggressively fluid resuscitate them. Not to mention their inpatient stays are longer, they're less time in the ICU, they're back home with their families, and as I like to say, they're back home paying taxes and contributing to society earlier. They're not going to rehab facilities and all the other prolonged things that happen with deconditioning from being inpatient too long. So how much fluid do these people need, right? That's always the next logical question. So we've said hit them hard, hit them early, move to pressors early if that's what they need. how much fluid should I be talking about before I worry about putting these people into heart failure, right? That's always the balance. So when you look at the fun, innovative names to the trials from before, so Process and Arise, both of those were given their patients about 4 liters of IV fluid over the first 8 hours of their stay, as compared to the Manny Rivers early goal-directed therapy. He was in the 5.5 to 7 liters of fluids, right? So the problem is if you go overboard with your fluid resuscitation, you've seen this before, people just turn into the Michelin Man, right? That fluid, the capillary beds get leaky, they go everywhere. They start to develop fluid overload, pulmonary edema, they develop respiratory distress, and they'll need to have either BiPAP. Sometimes they'll need to be intubated if you go overboard on their fluids. So really the management in the ED is going to be aggressive. I don't want you in the EMS world or even in the ED world to worry too much about going over on their fluids, because unless you're hitting that 5 liters in the ED, which you could, you probably won't, they need to be resuscitated first, okay? But if you're in a liter, you're in 2, and they're still hypotensive, keep fluid resuscitating them, but have a pretty low threshold to get the pressors on board. Next question. And I love this one because I get this all the time in the ED. What fluids do you want to give, doc? Facebook told me that normal saline is bad, and if you give saline to people, you're a monster, and you're actively trying to harm them. Okay, is that true? I don't know, but there is a pretty great study out there, and once again, it's got a cool name. It's the SPLIT trial, and the SPLIT trial. This is from, what year? I believe this one's 2014, if I'm not mistaken. So the SPLIT trial, what they did basically was they looked at the effects of normal saline for resuscitation, and they compared it to buffered fluids, looking at patients who were in the ICU. They were looking at acute kidney injury and lung injury on the 2 patients. Long story short, they found no difference between the 2 groups. So whether you give them saline or you give them Hartmann's or PL 148, the plasma light 148, or lactated ringers, we end up getting to the same place at the end of the day. Okay. The problem is, you look at these and they say saline is bad for people. There are some people that it is bad for. But the thing that's even worse is being hypotensive and being in shock to begin with. Okay, right? This is sort of like the study that says parachutes are killing people that jump out of airplanes. It's not the parachute that kills them, right? It's the jump out of the airplane that kills them, but that's how sometimes data can get turned around on itself. What pressors do I pick? This is the next question that I get all the time. Great article from New England Journal of Medicine looking at dopamine and norepi and the treatment of shock. Again, going from top to bottom, norepi seems to be the best option, then vaso, then epi, and then everything else is beyond that. So I don't know what all of you carry in the backs of your ambulances, but here in Dane County, we did make a very conscious decision to move towards norepinephrine as being our pressor of choice, followed closely by epinephrine with epi drips. And then we have taken dopamine and we've moved it almost completely out of our protocols at this point. How do you assess their fluid status, and how do I know if I'm going the right direction with the IV fluids like we were saying before? This is the first 4 are physical exam findings, right? What's their heart rate doing? Are they still tachycardic? Are they still hypotensive? Are they becoming more tachypnic, or are they going in the right direction? Look at their blood pressure, including their pulse pressure, right? How wide is their pulse pressure? Do a good lung exam, listening for those coarse breath sounds. You know that crackly sound when people are starting to fill up with fluids. You can look for JVD, right? It's the paramedic student's favorite exam, to lean someone back to 30 degrees and have them turn their head and see if they've got those bounding venous distension. Urine output, if you're measuring urine output in the back of the ambulance, I'm sorry, It does happen sometimes. This is probably one that we'll end up doing more in the ED or in the intensive care unit, but using urine output as a measure of how well resuscitated your patient is. The IVC respiratory variation. So this is a pretty cool one that you can slap an ultrasound probe on somebody's abdomen or underneath their xiphoid process. You can take a look at their inferior vena cava, and you can see how much does it rise and fall with each of their breaths. If it's got a ton of variation, it's a good sign that you probably have some room to go up with your IV fluids. If it's staying pretty constant, it's a marker that your tank is full, and you should move on to pressors if they're not meeting their blood pressure requirements. Pulmonary edema, a lot of times we pick those up on x-ray, but we'll also see them on bedside ultrasound, right? So you can look for those sandy beach signs, and then a bedside echocardiogram. Not mainstream and not prime time for EMS services here, but if I was to take my magic wand and my crystal ball and shake them up and wave them around, I would point ultrasound at the pre-hospital world as being another arena that I would love to see POCUS start getting used more, right? So you can use it to ultrasound lungs, look at hearts, look at IVCs, and use it as a marker for your resuscitation. You definitely have to modify this a little bit. But again, remaining hypotensive is worse than having a little bit of pulmonary edema. So I start with maybe a little bit reduced IV fluid resuscitation on those people. I do move to pressors more quickly. But if push comes to shove, I will start them on positive pressure because they do need to be resuscitated for their sepsis. But great question. That's where a lot of the art of medicine comes in. Last two on this list that are turning nice and blue really are only partially the realm of EMS and the emergency department, right? So these are source control. So if someone is septic because they've got a ruptured appendicitis, if they've got an infected kidney stone, if they got a hot gallbladder, a lot of these are going to end up being surgically managed, right? So they'll have to go either to the operating room with surgery, or sometimes interventional radiology will get involved and help with the source control. And then the last step is ICU care, right? And the ICU care, I put this one at the bottom because if we do 1, 2, and 3 well, we might be able to pull those people back from the edge of the cliff before they even get to the intensive care unit, right? So if someone turns around in the emergency department or turns around in the ED, like we like to say, it's a win if they go to the step down unit or sometimes even the floor if we're really aggressive and on it. I tipped my hand a little bit earlier, but I mean every bit of this. The early detection and the early IV fluids are 100% the realm of the pre-hospital providers. And then that early antibiotics portion it's totally in your lane too, right? If you're calling me and you're saying, I got a guy who's here, who's septic, code sepsis, listen up, Lohmeier, code sepsis, I'm coming in, this guy's sick, and I've identified it. Even though you're not the ones who are drawing up and pushing those antibiotics, you're the ones who are saying like, hey, stupid, pay attention. I got somebody sick here, and we can cut that first hour out, right? Like they hit the door, we got our cultures cooking, and we've got our antibiotics in within 15, 20 minutes if we're getting that early heads up, right? How do we do this? So every place is different, and I said this at the beginning, and I'm going to continue to say this. This audience is incredible. Like I cannot tell you how grateful I am to be able to reach out and interact with so many people from so far across the state and the region. This is just one example of how we can coordinate the teamwork that happens. In the Dane County protocol book, we've actually got a sepsis screening protocol in the back. Impossible to read probably on your screen, but magnifying it a little bit. What do I want you to do? Look and see if they've got those SIRS criteria. What are they, right? So hot or cold. Are they have chills or rigors? We kind of threw that one in as a bonus. Are they tachy? Are they tachypnic? Are they altered? And then are they having problems with their glucose management? If the answer is yes, and you think they have an infection, you're calling a medical red and you're calling sepsis alert to the ED so that we're ready. Okay. The one caveat that I would like to pull out here, and again, not knowing how everybody who's listening system works, but I'm assuming they're pretty similar. At the U, if someone calls and they say, I got a STEMI alert, we're going right to the cath lab, or you're getting met by interventional cardiology in the room. If they call and say, I got a stroke alert, we're going right to the CT scanner and we're getting met by the stroke team and neurology. I got a trauma alert, you're going to one of our trauma bays, the full trauma complement is meeting you there. You call and say, I got a sepsis alert, it feels just like every other patient I drop off, right? But there is a lot of extra things that are happening, and they're kind of subtle, right? So what you'll notice when you call that sepsis, that medical red sepsis alert, the tiny little bottles that are blood culture bottles are already going to be pulled out. Probably 2 sets of them. You're going to see that the fluids are already there and spiked and ready to go. And we may even have our pharmacist ready at the bedside too, so that we can start our pressor mix and get them going, right? So it maybe doesn't feel as dramatic as some of the other alerts that you get to call. But I will argue, going back to the point a few slides ago, 1.5% increase in mortality for every hour that we don't get on it. That's huge, right? And that's probably more dramatic than if we broke down the sexy STEMI alert, trauma alert, stroke alerts, right? You have the power, and it is something that could easily slide by, especially in a busy ED. These patients unfortunately could get neglected if you aren't, again, kind of grabbing me by the collars and be like, hey, take a look at this guy. He doesn't look good, right? What should be the first line IV fluid initiated for a hypotensive person suspected to be in severe sepsis? A, D5W, B, normal saline, C, norepinephrine, or D, rapid infusion of diesel fuel. Yeah, so saline should be your first line, right? If you want to choose saline or lactated ringers, I would refer you back to the split trial, which would say it's probably a push, whichever one you are more comfortable with and whichever one you prefer. All right, so we're going to finish up with a case. Case number 2. 67-year-old male with a past history of metastatic prostate cancer, PE on Lovenox. He's got a pulmonary embolism. He's anticoagulated. He's got C. diff colitis, who calls 911 because he's got urinary retention and inability to urinate. First contact vital signs. He's got a blood pressure of 141/82, heart rate 111, respiratory rates 18. His temp is 99.3. Nice job getting a temp on this one. And he's 95% on room air. Any thoughts? Those are actually, he's a little tachycardic, but otherwise his vital signs look good. If we're looking at our SIRS criteria, right? He's not tachypnic. He's not hypotensive. He's maybe a little tachycardic. His mental status is normal as far as we know here, right? But this astute crew did not stop there. He got into the ambulance and started transport, and they repeated his vital signs, which is something I cannot overstate, right? Serial vital signs are amazing, right? It's kind of like a GCS in a vacuum. It doesn't mean anything. It doesn't mean much. Vital signs in a vacuum don't mean a whole lot either. Where are they going and what are they trending? Repeat blood pressure, 175. Heart rate's now bumped up to 140. He's now got a fever at 100.6, and he's hypoxic on room air at 90%, right? So now we just tipped over into 3 out of 4 SIRS criteria right there, and you picked it up. This guy's sick from probably a urinary source. So to finish this one out, sepsis alert medical red is the call. On arrival, when that patient hits the door, there's an overhead code sepsis that gets paged out. The full team hits them in the room and they meet you up. They get the story. As they're listening to the EMS report, his blood cultures, his lactate are drawn, his fluids are started, his big gun antibiotics are started. They do put a Foley catheter in, and they notice that he gets feculent material out, right? So he's got stool coming out of his bladder, which is awful. His blood pressure remained stable throughout. His heart rate improved with fluids. And then for this guy, he ended up getting admitted to the IMC. So he went to the step-down unit. He ended up having what's called a colovesicular fistula. So there's a connection between his colon and his bladder, which is why he's getting stool coming out of his bladder. It was able to be surgically corrected, and he ended up going home from the hospital, I think it was 4 days later. Okay? Big time save. For comparison, our case number 1, I don't think that there was a delay here, but unfortunately this guy was maybe a little bit slower to get some of his antibiotics on board and his pressors. He took time, right? They were kind of managing his airway and other issues for that first hour up front. He ended up being inpatient for significantly longer. He came in at the end of January, didn't leave until the beginning of February. And he unfortunately ended up having to go to a rehab hospital. A few other complicating things with this guy. He had also metastatic prostate cancer that hadn't been diagnosed yet, but his big potential miss was just the timing to getting his antibiotics on board. All right. So again, just to drive this point home, it changed my outcomes. Is not supposed to be highlighted, nor is antibiotics. It's supposed to be detection and IV fluids. But again, this is 100% the realm of EMS, right? Be tuned into your patients. Listen to what they tell you. Be a good historian, and repeat your physical exam and your vital signs. I cannot overstate how important it is. And those early calls, that great communication to the ED is 100% what saves lives. Okay, it's that warm team handoff. I will say it. I have said it every day, and I'll continue saying it for the rest of my life. You are invaluable and one of the most critical members of our team, because you have information and you have the first touch that I will never get an opportunity to have. Right. So making sure that we have a good teamwork and good communication is enormous. Any questions? Yeah, great question. So it's all going to really depend on their respiratory status and how well they're able to compensate, right? So if they've got a big metabolic acidosis from having poor tissue perfusion, and they've got good respiratory status, much like a DKA patient is going to kick up their respiratory rate, a normal patient could kick it up, and they might end up having a low end tidal CO2 because they're trying to compensate for that acidosis. Now, if they've got bad lungs, it could be anything, but if they've kicked up their respiratory rate, I would expect them to have a low end tidal. Great question. Yes. And so that is going to be the answer is a little bit nuanced in that there really isn't like a sepsis center of excellence. We don't have the stroke centers and the STEMI centers and all that. Anybody deals with sepsis daily, and they should be able to deal with it daily. So your community hospital would be totally appropriate for those. Again, every minute that you add on to these patients' time before they get their cultures and their source control and their antibiotics is going to impact their outcome long term. So community hospital would be appropriate. Now, the nuance or the caveat that I would put on it is if it's a complicated surgical patient, or if they've got, recent surgical interventions that have been done at the big medical mecca, and you've got to choose between, I'm going this way or that way, probably would make a little bit more sense to go back to where they had their big interventions, right? So I'm thinking patient had a heart transplant and now they're septic because they've got infected hardware in their chest. They may be better off at the tertiary care.